an underestimated problem in handball. Does this work? We recently published a book on handball sports medicine and science, and it covered various topics from basic science issues, biomechanics, injuries, rehabilitation, psychological aspects. But one of the things that occurred to me is that in terms of, there were a lot of injuries related to the head, neck, and face region, but nothing on concussions. And myself as a team physician, I saw quite a few of those. So it's probably underdiagnosed. It's not surprising that it's a common problem in handball, because handball is a contact sport. It's a very dynamic sport, very fast. So you get a lot of unexpected cutting movements combined with the contact sport. So you'll get a lot of head, neck, and face injuries. And if you look at the literature, actually you can see that head and face injuries are quite common. They're not rare. There's just no data on concussions because the diagnosis of concussion wasn't very common. It wasn't a very hot topic until recent years. So in several studies, it was actually the most common diagnosis. But again, no reference to concussions. So head and neck, head and face injuries, but nothing about concussions. And again, various studies from all over the world, from Africa, Asia, Qatar World Championship in 2015. So high prevalence of head and face injuries. The majority of those are obviously contact injuries, but again, nothing on concussion. If you look at the data from the VBG, you can see that head and face injuries are as common as in other sports. Leave hockey aside, it's a different type of contact sport. But if you compare handball to basketball and soccer, you can see it's same rates. And mechanisms are obviously contact. The way the VBG distributes the mechanism is slightly different. So if someone is pushed and hits his head on the floor, it's not regarded as direct contact, but it's a contact injury. So yeah, mechanisms, common mechanisms in handball. So goalkeepers are obviously a population at risk. We've all, as players, coaches, or people around handball, see these events occurring quite commonly. And what usually happens? Goalkeeper, for a few seconds he'll be out, maybe substitution, but he'll go back and play. And is it the right thing to do? And it happens a lot in practice, not only during matches. And there are other situations, again, as you can see on the right video, again, a goalkeeper, blow to the head, but it could be a follow-up after a shot, like on the left bottom video, or a contact with the floor, with the court, in the top left video. And other common mechanisms in handball. It's a dangerous situation where you can see two players on fast break. So we see that quite often. And low energy can also be quite traumatic, as you can see here. And the consequences of brain damage can be quite devastating. So this is a famous Danish player who sustained a head injury from a ball which was thrown not from a big distance. She suffered a concussion, but it was not diagnosed. And she nearly ended her career because of this. She was out of sports for more than a year, and it affected her personal life in a way that she nearly lost control of her. Well, she did lose control of her personal life for a long period because it was not diagnosed. It's not a matter of diagnosis, it's also addressing this. And she started suffering from psychological effects, difficulty sleeping, functioning, and it affected personal life, being a mother as well. So it's it was a huge story in Denmark not too long ago, from a simple ball to the head mechanism. Recently, we've learned that a history of concussion is associated with symptoms of common mental disorder in former male professional athletes across a variety of sports, including handball. And we all, I think many of us are familiar with this movie, which is based on a true story on how the concept of concussions was for many years neglected in American football and the NFL. So what is the current state in the IHF, EHF? Well, basically, we know there's a high risk of head and face injuries in handball. There's insufficient data on concussion epidemiology, its diagnosis and management. There's a lack of proper guidelines and education on the topic for medical personnel and referees. Referees are an important part of this. And what about protective equipment? You know, it was an issue in the past. Goalkeepers were allowed to use special soft head protective gear, which is not allowed currently. So there's a great need for intervention, definitely. So what we're trying to do is set up studies, and we're in advanced stages of doing it in several countries, and hopefully in Germany as well. One of the things that we've done is use an existing app for injury data collection, the SIOMS, the Sports Injury and Overuse Monitoring System, and add a special sequence to manage head injuries and concussion. So through this, you can just provide basic data on players. It's an app which was designed especially for handball, so it's easy, quite easy, user-friendly. You can add on the baseline information for each player in the team, and again, pre-concussion state, data regarding the concussion, and post concussion state, and you can keep this, and then if this player has another event, then you can go back to how it was managed previously. The French Federation realized that concussions are an issue, so they provided some guidelines which are used by the French League and the French Federation. For those who don't speak French or read French, I'll try and go through the essentials. So basically, any suspicion of concussion must lead to the removal of the player from the match or training. No return to match or training while the symptoms persist. It's important to understand that a lot of times the coach or the team physician or the physio asks the player, "Oh, can you go back to play?" But the truth is, it shouldn't be done because maybe the player is not in a position to make this decision. Maybe he's disoriented. So there are a few definitive criteria for removal from the match. Obviously, loss of consciousness, even for a split second, or even if there is suspicion of loss of consciousness, the player should be removed from the game. No response to simple orders or no movement, and suspicion of loss of consciousness could be defined by cervical hypotonia, player being motionless on the ground for a few seconds, eyes closed, ataxia, defined by difficulty to get up, to stand steadily, or to walk normally and steadily, even if it's for a few seconds. If the player has a dazed, vague look, if he seems confused, makes inappropriate remarks or repeats the same thing for a few times, if he seems disoriented, makes any abnormal statements, doesn't recognize the people around him, if there's clear behavioral change, agitation, or inappropriate response, and convulsions. Criteria for evaluation are basically any head or facial trauma, even without obvious evidence of a concussion. So when you're in doubt, you need to take them out. The player has to be examined in a clinic hospital if there is immediate memory and delayed memory loss. And you can perform simple tests like the tandem walk test. It's a step-by-step test that they need to be able to do. It's an easy test, and you can use this test as baseline. And also, players who were taken out or there was a suspicion for concussion should be examined again before leaving the locker room and going home or wherever they're, or to the hotel. This is an important aspect of the evaluation. Another evaluation should be made 48 hours later, and this the diagnosis of a concussion is made summarizing the symptoms during these 48 hours. So it's very important to repeat this examination 48 hours later. Return to sport. After each concussion, a step recovery is needed. It's not just having them rest. There needs to be a structured rehabilitation, and there are a few guidelines that I'm going to go through quickly. If a second concussion occurs within 12 months, the player should be out for 2 weekends without 3 weeks of stopping any play, with 2 weekends without a match. And a third concussion within 12 months should warrant their removal from play for 3 months, with thorough evaluation, obviously. These are guidelines by the CISG, Concussion in Sports Group, for gradual return to sport based on kind of a phased rehabilitation. And they have published similar guidelines for kids who suffered a concussion in terms of return to school. So it has to be staged. Even simple tasks as walking, concentrating for 5 to 15 minutes is difficult after a concussion in any individual. So this is a summary, again in French, to the French Federation. So it's for the French-speaking individuals. Feel free to copy this. Pre-season testing. It's not too difficult to do this. The tandem test is one of these. The double support, single support, and tandem tests are easy to do, and they take literally 2-3 minutes. At the highest levels, where you have some more advanced technologies, there's ocular motor impairment, eye movement for baseline and for concussion assessment, vestibular balance dysfunction, several apps that could monitor this, cognitive fatigue through questionnaires, the SCAT-5, and assessment of the cervical spine as well. So to summarize, handball is a sport with a high risk of injuries, and head and face injuries are very common in handball. There's no data on the true extent of concussions in the sport. There's a true need to study the extent of the problem and strategize prevention and management measures. And upcoming studies will lay the grounds to address this issue in terms of guidelines for coaches, for referees, for medical staff, and regulations. So the bottom line is currently that when you're in doubt, take the player out. Thank you very much. And we will have a special day in Spain, in Pamplona, in June. So if you're around, you're invited, and we'll talk some more about these topics and other injury and injury prevention topics. Thank you.
Thank you very much. Some questions, maybe? Remarks? Yes?
So we don't plan on separating, but we are planning to do these studies in different populations at the highest levels and the amateur levels, because one of the features that we are interested in looking at is how they are managed in the decision making. Obviously, a team, an amateur team, which trains maybe 2-3 times a week, they don't have any medical support, not even a physio or a sport therapist. How is this managed? Who manages these injuries? Does the coach send them somewhere? They do that themselves? So this is something that we want to get into and understand.
Yeah.
You hit me a lot of times. And actually, I thought the ball is this. Yeah, no, but it's fun. But you know, I think from the professional perspective, there's a lot of professional mentally also. And the people who are in this area of high performance need to perform and have the pressure of the stress mentally. So I think in Denmark there's huge publicity right now. In each game, all the commentators say, "Oh, stop, maybe
Yeah.
you get a lot of."
Yeah.
And people are also like, "What is it?" And you see this kind of publicity can also do
Yeah.
people to be a little more unrestricted. Because actually, if I ask my dad, I don't remember one time people get this kind of thing.
Yeah, but this is the other side of things. That this is the norm. But this is why we need to do this. And to understand it better.
This may be a stress factor for professional players in the career. Okay, why did I get a chronic illness? My last year of my season, because I didn't know what to do after.
Yeah, sorry, this is so interesting, really, topic. We will discuss maybe later, but we are so late, so I would like to thank you very much again. I would like to introduce next speaker. We are going to goalies and also to injuries. And our next speaker is Martin Erdrich. I hope that I pronounced that. Martin.
Yeah.
Well, it's a shame I'm after this talk about head injuries, because compared to head injuries, elbow injuries seem a small problem, but I think we have to discuss it also. So my question is, handball goalie's elbow, is it still a big problem? Why this question? A long time ago there was a study by Teerdal and Barr, and they found that there was a high prevalence of elbow problems among goalkeepers in European team handball. Sadly, since then there hasn't been much attention. Again, in epidemiology studies it hasn't been shown, because often goalies were not separately analyzed. And in practice we still see a lot of handball goalies with elbow problems. So As one of the several studies we did on injuries in Dutch handball, we wanted to look at prevalence of elbow complaints in Dutch handball goalies. We wanted to look at etiology and complaints, and we wanted to find out whether there are treatment and preventive options that we could learn from these handball goalies. We did a cross-sectional online survey in March 2018, and we included handball goalies 16 years and older, and we wanted to know whether they had current elbow problems in the previous 4 weeks, whether they had problems of the elbow in the previous half season, or whether they had any elbow problems during their career. And we also asked them to fill in an Oslo Sports Trauma Research Questionnaire and a numeric pain rating scale, and we asked them about contributing factors. Overall, we had more than 800 respondents, and 67% of these were female. Handball is more popular in women than in male athletes. Over the current season, there were 448 respondents, and there were also a lot of respondents which were former handball keepers. On senior level, there were 331, and there were also more than 100 junior players. Well, if you look at career prevalence, there was a career prevalence of more than 50%, and in retired goalies this was even higher, more than 45%, 54%. The half-season prevalence was 27%, I'm sorry, and the current prevalence was 29% even. When we look at the Oslo Sports Trauma Questionnaire for current problems, they filled it in. It was at a score of 30, a numeric pain rating scale of 4.8 on a scale of 10. Most injuries were acute in onset, and the duration of complaints were less than 1 week in 30%, but more than 4 weeks in more than 40%. When we look at the arm, the throwing arm was more often injured than the non-throwing arm, and both sides were injured in 33%. And there were several locations equally mentioned, lateral and medial location. Dorsal was less, and 25% also had pain in the forearm. When we also asked about other complaints, and there were a lot of handball goalies with problems in range of motion or locking. 26% found had weakness of their elbow muscles, and also 25% had tingling sensations in their lower arm or in their fingers, and 18% experienced instability. Contributing factors are important because when we know what factors contribute to the problem, we can define preventive measures to prevent these injuries. Of course, the shot impact was mentioned most often, but also overuse, which implies that repeated shot impact is also a big problem. Intrinsic factor like weakness and techniques, goalkeeping technique were mentioned often as well. 70% mentioned previous injuries, and 16% mentioned focus, which might be an important factor as well. And only 12%, we thought that would have been higher, mentioned playing in higher teams as one of the contributing factors. What treatment did they get? Only 45% had treatment for their injuries. Almost all of them went to a physio. And bracing and taping was the most mentioned therapy. Strength training, extra strength training, and reduction in training and game participation, only 20%. And after they healed, or after they went back to sports again, bracing and taping and extra strength training were used as tertiary preventive measures. When we asked people about their career experiences, we saw that of all the people that had problems of their elbow, 28% had problems once, and more than half had several problems, and 20% had yearly problems for several years. Which is something noticeable is that 57% never had a time loss episode. 24% once, and 70% several times. What we think is that goalies are not allowed to stop because they're the only one that are in the goal, and they have the drive to keep on playing because their team is dependent on them. For 19% of the goalies that stopped playing, one of the reasons to quit was their elbow problem. Well, this was a cross-sectional design, so it is possible that there was a response, a bigger response from handball goalies that had problems, which we see in the higher current prevalence compared to the prevalence of the half season, but still there were a lot of goalies that didn't have problems that also responded, so we think it's a big problem. Recall bias could play a part also in problems of the whole career, but we think that someone who has had elbow problems will remember whether he had elbow problems during their career, because it's always a painful situation. So we think handball goalie's elbow is still a big problem, and preventive measures are warranted. Thank you for your attention. Was I inside the? Okay.
In general, we are late, and I'm sure that we will discuss after that. So, I would like to introduce the next presenter.
Yeah. I will represent him because he couldn't come. So I will. Yeah, I'm not Tim Arndt, but
okay.
I cooperated. Well, as a part of several studies we did with the Dutch Handball Federation, we also looked at prevalence of injuries in Dutch team handball, and one of our students did a survey on that, and we'll discuss these results, the preliminary results. As you know, Dutch team handball has gained popularity since the recent successes of the Dutch national team, but there are also a lot of injuries. And in Dutch handball, effective preventive measures need to be developed and or implemented. So we had to know what injuries are prevalent in Dutch handball. Of course, there are a lot of studies in other countries, but we didn't know what injuries are prevalent in Dutch handball. So the purpose of the study was to investigate the prevalence and distribution of injuries in Dutch team handball, and to possibly identify what preventive measures need to be implemented or developed. We did a repeated cross-sectional online survey over the season 2018-2019. We included handball players of 18 years and older, of all playing levels in the Netherlands. We sent a monthly questionnaire, and in this questionnaire we asked about their age, gender, playing level and position, and about their ability to fully participate in handball. And if they had been injured, we asked about the injury type and location. And we also asked them to fill in the Oslo Sports Trauma Research Questionnaire score to see what the impact of the injury was. These are preliminary results from the period September to February 2019, I'm sorry. And in this period, we had overall 1,148 respondents, and they filled in 2,290 questionnaires. First, the monthly prevalence, which is around 40%, which means that 40% of respondents mentioned that they had been injured that month. When we look at new injuries, and we look at the distribution of new injuries by body location, you can see that knee injuries were most mentioned with 20%, and ankle was also mentioned a lot. And within the 27%, there were, I just looked it up, there were 2 concussions mentioned by Grzegorz. But as you can see, it's not a big amount, so we're not really focused on that. Perhaps that's not a good idea. But when we look at the cumulative injury prevalence and mean Oslo Sports Trauma Research Questionnaire scores, you can see that knee injuries are most commonly mentioned. I have to say that when respondents had a knee injury or any injury and they were not able to participate for a full month, they had a score of 100 in the Oslo Sports Trauma score. And there were a lot of long-term knee injuries, ACL injuries. The good thing about this way of registration is that you do not only see what new injuries occur, but you also see what the impact is during the season, because these people are not able to play for a long time. And you can also see that some injuries are have less scores, so might be less important to prevent, like for instance finger injuries, while other injuries have higher scores and need to be prevented. So not only the frequency of injuries is important, but also the impact. We also looked at distributions by sex, and there were no great differences between sexes. Both male and female athletes had similar percentages for knee injuries. These percentages are referenced by the total of injuries reported by different sexes. And ankle injuries were also quite similar. Only lower leg injuries were more prevalent in female athletes than in male athletes. When we look at injury distributions by position, we see that for all positions, knee injuries were mentioned most often. Ankle injuries were quite prevalent in most positions, but slightly lower in wings. Keepers had lower prevalence of shoulder injuries, but they had higher prevalence of elbow injuries. And lower leg was quite high in wing players. So maybe there are some issues about these injuries that can be related to specific positions or specific builds of players in specific positions that need to be investigated. Well, this was a preliminary analysis. We have to still do the full analysis, and one of the problems with our design was that it was a repeat cross-sectional design. We chose this design because we wanted to reach as many players in the Netherlands as possible. A lot of studies are with high-level players, and in a context where injury registration is mandatory or easier made, but we wanted to have insight in what the injury prevalence is in community handball, so that's why we choose this design. Another problem, well, a minor factor is that we only included the players 16 years older, but that's part of privacy and consent. It's more difficult for younger players, but of course younger players can also have injuries, so it would be interesting to know what their problems are. And we have to certainly have to start injury prevention before the age of 16 years. Last point is that we let people fill in the Oslo Sports Trauma Questionnaire over 4 weeks, which should be over 1 week, which would have had a bias in scores, but not in the comparison of scores. But the conclusion is that injury prevalence in Dutch team handball is high, and that the distributions by body locations are compatible with earlier studies from other countries. So I think it is okay to say that preventive measures that have been proven effective in other team handball populations should be implemented in Dutch handball, and perhaps some extra measures. Thank you for your attention.
Also very interesting study. Questions? Excellent. Yeah, this is the best comment. So, and slowly we are coming to last presentation. Piotr Kontimarek is the presenter with quite interesting title. Huh?
Not the boring one. No, I don't have it.
No, it's not boring, it's interesting. But I will leave to you that you will explain.
Okay. Good evening, everyone. Few seconds we need, yes?
Yes.
Yes, exactly. This is it. Okay.
Which is so important in handball.
Yes, quite important, I believe. Pathoanatomy evaluation management of traumatic and atraumatic posterior shoulder instability. Glenohumeral instability is quite common condition that we can see, but when we focus mostly on the posterior instability, we can see that it affecting only 2 up to 10% of all unstable shoulders. So it's quite not common condition, and because of that, this is also a very missed condition during the initial evaluation. As you can see, this missed ratio is between 60 to 80% of all diagnosed problems within the shoulder. So generally, they are misdiagnosed as frozen shoulder or maybe the shoulder pain generally. So this is a huge problem, and especially we should focus on this and the proper diagnosis of the posterior instability. Because of that, it can lead, of course, to posterior dislocation, which is quite rarely seen, really, because and this is quite obvious, of course, problem. But generally, we have the posterior subluxation, and the most common type is this recurrent posterior subluxation. The most common patients are, of course, overhead athletes, yes, so throwers, swimmers, but also the football players and weightlifters. So because of this special clinical and radiographic characteristics as well, the proper diagnosis is the diagnostic trap, really, for the posterior instability. Yes, because, as I said before, we've got many cases missed by the physicians who first see the patient, and also the appropriate treatment is delayed because of that. And this causes for delay, besides this failure by the physician, is also the late presentation by the patient, and also inadequate radiographic investigation. And it can lead, of course, to chronic pain, stiffness of the joint, functional disability, and a huge problem for our player, and to restore him to the proper performance, proper level. almost all elements, all structures of the joint are involved in this pathology. So we've got, of course, the static stabilizers of the joint, like capsular ligaments, capsule itself, glenoid labrum, intra-articular pressure or articular cartilage surface. Additionally, the glenoid version, humeral retrotorsion, joint congruency. All these factors and any problem in each of this element can contribute to the posterior instability, and all of that we should check. All of this we should be able to evaluate properly. Of course, the labrum increase our glenoid depth, concavity and surface, but the most important part is the capsule, the posterior capsule especially. So the space between the intra-articular portion of the biceps tendon and the posterior band of the inferior glenohumeral ligament complex. This is the most important element. It restricts the posterior translation of the head of the humerus, yes, but also this is the weakest and the thinnest part of our capsule. In case of dynamic stabilizators, of course, we address to rotator cuff and especially to the subscapularis muscle. Also, this muscle, of course, work together with infraspinatus and teres minor. So first we address, of course, to this muscle, but we shouldn't check only on this local area. Yes, we should more globally, we should check the whole posture of our athlete, the core stabilization as well. Yes? So we should address more elements to this evaluation. Thanks to the muscles, we've got two main dynamic stabilizing mechanisms. We've got the concavity compression, which is provided by the rotator cuff muscles, and also the scapulohumeral rhythm, which is coordination between the rotator cuff muscles, deltoid muscles, and all other muscles that surrounded the shoulder girdle. The primary injury mechanism in this condition is usually the repetitive microtrauma or acute trauma, or sometimes the insidious laxity, so the stretching of posterior capsule and passive stabilizers. But the primary injury is quite easy to diagnose. The most problem is with the secondary injury mechanism. So all abnormalities of anatomy, large reverse Hill-Sachs injury, glenoid dysplasia, connective tissue disorders, like for example Ehlers-Danlos syndrome. This is the huge problem, maybe not to evaluate, but to manage properly with proper rehabilitation, and also the voluntary or habitual shoulder dislocators. And this is the special treatment group, because in these cases we also should understand that here the huge problem is also the psychological problem with these patients. So the rehabilitation process is totally different when we should address to them totally different approach, because we should distinguish between positional dislocators who are able to subluxate or dislocate their shoulder by altering scapular positioning, and they usually can address by stabilization operation. But something different is when we have the habitual dislocators. They are so-called party trick shoulders. Yes, so they can dislocate their shoulder by special movement patterns, by special activation of the muscles. They are much less painful or even painless, and here the surgical intervention should be avoided because of the poor outcomes. So because of that, because the diagnosis and the treatment is extremely challenging in this condition, we've got this huge diagnostic trap here. Of course, the clinical picture of this patient is maybe not so strangely, because we've got nose striking deformities. Yes, we've got this feeling of posterior fullness and rounding. We've got the prominence of coracoid process, severe limitations of external rotation. Also lack of pain during external rotation, especially in chronic dislocations. Also limited elevation, especially above 90 degrees. But because of this picture, yes, here, this is the same picture as we can see with shoulder contusion, for example, or rotator cuff tear. So this is why this is so problematic to diagnose properly. And additionally, we've got severe swelling that hampers the diagnosis. AP radiographs, this is typical what we do. Yes, we perform the AP radiographs, but unfortunately a standard AP radiograph will not do the thing here because they appear grossly normal. Light bulb sign is absent in most cases. So axillary view or Y view should be addressed here, but also but this type of imaging is often neglected. So these factors may contribute to the high rate of misdiagnosis. Also, the history of the patient is quite common, yes? The pain, aching pain and weakness along the posterior joint line, biceps tendon, or superior aspect of the rotator cuff. This is general description of the painful shoulder, yes? So nothing special here. Symptoms may intensify with the arm in 90 degrees of forward flexion, adduction, and internal rotation. Okay, so this is the typical position, yes, for posterior dislocation. In case of athletes, something that we should take into account is that the symptoms increase during the game. So because of the muscle fatigue, there is a decrease in dynamic stability. And that's why, because during the game, at end stages of the game, they can feel more unstable and more painful in this condition. Of course, we've got special clinical tests like posterior drawer test, jerk test, or Kim test, from which the highest sensitivity and specificity has the Kim test. So during the clinical evaluation, of course, we use this battery of tests. As I said before, also we've got the radiograph image, yes, but as I mentioned, the separate AP radiographs usually looks normal, yes, so we've got normal bony anatomy in these cases. What we can see on this is reverse Hill-Sachs lesion that may be found, yes, but we also should address other projections like axillary view or Y view. Thanks to them, we can be more precise. Even this diagnosis rate is up to 100% uses these three projections. When we use only AP view, the diagnostic rate is at 11%. Of course, we may use further other imaging equipment like MRI for soft tissue pathology or CT for evaluation of the osseous. But this is something that we can add later, yes, when we have problems with proper diagnosis, or we want to manage what else should be addressed, or when we should plan our surgery. The first line of treatment always should be non-surgical approach, so activity modification and conservative physical therapy. But there are two exceptions mostly, so all the bony pathology of the glenohumeral joint, and the second one, the traumatic instability. In both these cases, usually the non-surgical treatment has poor outcomes. The duration of the first line of treatments on this non-surgical treatment should be at least 6 months, because mostly they say that 3 months is okay. Now, in this condition, we should keep to the program for 6 months, and after that we should consider maybe the surgical approach. The protocol is not very special maybe. But when I work with my athletes, I always say this time of the career, so the injury time, is also the time when we can address not only the pathologic district, of course, but this is the time when we can address all weak links in the kinetic chain, so we can improve all other elements that could be the reason for his condition. That's why we work not only in this one area, but look more globally on our athletes. The surgical approach, so the second line of defense hour, the indication is the failure of 6 months rehabilitation, but the contraindication is the habitual instability because of the psychological factor in these cases. I will not discuss of all the procedures we can use, but of course we manage with soft tissue procedures and osseous procedures as well, or accumulation of both these strategies. The general guidelines are like mentioned here. So for first 4 weeks we've got of course the sling. After that we start with passive and active assisted range of motion. After 2 weeks we start with full range of motion, we add some strengthening, and after the 5 months of rehabilitation we gradually return to previous sports activities and work duties. And this is how all the timeline looks like. Of course, only in theory, yes, because not always it looks so good in aspects of these dates here. But few things I want to address and show to you that we manage not only with the shoulder, yes, we manage with the whole athlete here. So as soon as possible, we start with addressing with all the corrective exercises. So for the whole kinetic chain, we start with techniques like the technique for snatch or clean, or technique for acceleration and max speed. All these elements that we can then address at the later stages of rehabilitation. As soon as possible, with cooperation with also personal trainer, we start with muscle hypertrophy, maximal strength and power, and all of this is at the gym sessions. So during the whole rehabilitation process, we think about restoring the full function of our athlete. In case of the shoulder, when we can say that he's able to return to his team, well, he has the full functional range of motion, no pain or tenderness, good strength, endurance and power of the muscles surrounding the shoulder, satisfactory clinical examination, and also no fear with his shoulder, and good psychological condition. And for the conclusion, what we should remember, we should remember about all the missed cases, yes? So this diagnostic trap in diagnosing the posterior instability, and the reason of the delayed treatment in these cases. We should distinguish between positional dislocators and voluntary dislocators because we address totally different rehabilitation programs. The X-ray, we should perform all 3 projections when we suspect the posterior instability to make sure of our diagnosis. Non-surgical management is our first line of defense, at least 6 months of therapy after, and the program should be, of course, properly planned for each player individually. The whole team is working together here, especially the physician, physiotherapist, personal trainer. And of course, we address the whole kinetic chain, not only the shoulder, but the lower body, core, and upper body. Okay. In telegraphic short, yeah, that would be everything. Thank you very much.
Thank you very much to this last presentation, and to all presenters. It was really interesting. As I mentioned, it's really pity that we don't have more time, but okay, in the evening, maybe during the dinner or tomorrow. But if somebody has one question now, it's warmly welcome. If not, I invite you to coffee break or whatever do we have. Now is sport hall actually. We have some lectures in sport hall. I'm not quite sure where it is. You know where is sport hall? Maybe to explain to people.
Here. Here.